sentito che è una malattia molto rara, magari sottostimata. Beh, allora bisogna sapere bene come fare a diagnosticarla, altrimenti sarà sempre più sottostimata e sempre più rara. Quindi non è detto che poi sia poi così rara. Quindi I have the pleasure to introduce you, and if you speak in English, I think, not in German, no.
No.
No. In Italian, no.
No.
Okay. If you, I would like to invite you to speak slowly for allow us to understand perfectly your speech. Thank you.
So, thank you for inviting me to Turin. I will try to speak slowly so that you can understand me. I hope there are a number of people here who are able to understand a little bit English, actually. My Italian is only for German tourists, so you barely understand that, unfortunately. Yeah, it is really a nice place, and to have something like this center here, actually, this is the dream of every physician, to have a place where physicians, patients, and relatives can come together and can have some education, can have some training, and learn new things together. And I hope that we have something in Munich in the next time, and I hope that I can get it before I will be retired and something like this. Yeah, progressive supranuclear palsy, we have heard a lot of things about that disease, and we see a lot of patients in Munich from that disease. And we try to establish a clinical diagnosis on the first hand to avoid that our patients have to go too often to MRI or other investigations, which sometimes really do not make a real difference. The image of this animal is a little bit unsharp because this animal only exists in Bavaria, and if you are not born in Bavaria, you normally cannot see it. We often have the impression when patients with PSP come to our department that the physicians who have seen the patients really do not know what it is, what kind of disease. Is it a Parkinson? Is it a PSP? Is it an MSA, you know? But we think if you do a really critical clinical investigation, you can tell in a very early phase of the disease that it is PSP. Okay, here I have summarized in the table some of the diseases which are differential diagnoses to PSP. It's the Parkinson's disease, the multiple system atrophy, the PSP, the corticobasal degeneration, and the dementia with Lewy bodies. You can see the annual incidence of the diseases, which are estimated numbers, since we still don't know the exact numbers, even not in Germany. For example, corticobasal degeneration is so rare that we do not have really high numbers. I mean, in our departments, we see a huge number of PSP patients, about 240 a year, but we only have 20 patients who have CBD. The mean age at onset is approximately the same in the diseases, as you can see. And the mean survival time is diminished in the diseases like PSP and corticobasal degeneration because the swallowing is diminished very early in these diseases as compared to Parkinson's disease. What is very important for the family is, do we have the risk to get the disease? And as you can see, for PSP, the risk to give the disease to your children and whatever is below 1%. In fact, in Germany, we do not know any family who has the disease inside the family. We have heard about reports that there are families out there who have a familiar form of PSP, but when we looked at them, it has not been PSP. cannot see in PSP patient is summarized in this slide. The alien limb syndrome. The alien limb syndrome means that mostly one arm is moving and the patient cannot control it. The hand is something doing anything, but the patient does not recognize it. This is very typical for corticobasal degeneration, as mentioned here. We very, very rarely see psychosis at the initial presentation of PSP patients. In fact, in the patients we saw psychosis as the initial symptom, it has been a patient with dementia with Lewy bodies. Cerebellar signs, signs from the cerebellum, the small brain, are not present in the initial phase of PSP. Dysautonomia, like blood pressure problems or even problems with urine, are very uncommon in the early phase of PSP. And also, PSP is mostly symmetric sign. So that means the disability starts symmetrically and not unsymmetrically. Okay, that slide summarizes the pathology of PSP. You know from brain examination, we have been able to go back and to participate the clinical symptoms in different subgroups. There is not the PSP disease, but we have different subgroups. The classical syndrome, which has been described actually 50 years ago in 1963, is today called Richardson syndrome. This is the most often syndrome we see in Germany and all around the world. However, there are some patients who are very close to Parkinson's disease. So we call them PSPP for Parkinson's disease. And as you can see, there is a progressive non-fluent aphasia, which is very linked to PSP. And also the pure akinesia and freezing of gait means that the patient for a long time have the disability in walking, which also looks quite close to Parkinson's disease. However, in this group of patients, we also see early signs of cognitive decline much earlier than in the classical PSP patient. Early symptoms of PSP before we have motor disabilities are vertigo and dizziness. We have a department of vertigo for neurological diseases, and a really increasing number of patients with PSP present initially with vertigo. There are some patients who suffer from vertigo throughout the disease, the entire disease, and we do not really know which of the patient or why they have vertigo or why they don't have it. The dysarthria, we had already a talk about dysarthria today, is present much earlier in movement disorders. Very early on, our personality changes. This is what the relatives report us, that the patient is feeling uncomfortable, he's getting easier, a little bit angry and something like this. And symptoms like that one, like personality changes, or small car accidents, are very significant for PSP, at an early age. They occur about 3 to 5 years before the actual diagnosis of PSP is made. The reading disability is mostly related to the gaze palsy, but I will show you in the next video also the square wave tracks. That means that the patient is not able to stabilize the view, are responsible for these reading disabilities. The overall aspect of the face of a PSP patient is well known to all of you. It's the hypomimia like in Parkinson's disease. We very often see an open mouth, the eyes are wide open, and the Cooper's sign. You may have heard about this. Is, when the front jaw is pressed always like I had that one. That means the Cooper's sign, which is not very often in Parkinson's disease, but you can see it in corticobasal degeneration. What is very typical for PSP is time maybe to go through the slide, but you can look at afterwards at home because you do have the printout. But there are certain eye movement abnormalities depending on the stage of the disease. In the frank gaze restriction, the early phase, we see already these square wave jerks, or the inability to suppress the vestibulo-ocular reflex. This is a picture where you can see these square wave jerks. You can see these signs. You see that the eyes are moving. The patient cannot control their eye movement. These signs are really best seen in a dark room and when the patient is not able to fix any light source. Very interesting, the lid retraction is not very consistent in PSP patient. We call this the lazy lid sign. In normal convergence, when you ask a patient to look on its, or a normal person to look on its nose, you will see that their eyes are moving like this. However, in PSP, we know that there is a problem with the convergence. If a patient with PSP looks on its nose, it looks like this one. Additionally, in the PSP patient, the eyebrows are not going as deep as, like example, in the normal patient. Unfortunately, you can't see it on that picture, but you can see the difference. In a normal person, he is actually the husband of her. The eyes are almost closed when you look at your nose, but in the PSP patients, the eyes stay wide open, and you see the conjugated eye movement to the right side, which is very typical in PSP. It does not happen in Parkinson's disease, and we haven't seen it so far in CBD. What is always very visible in PSP patients is these small tears here on the eyes. Tears are running out of the eyes because the ability to close the lid is reduced. You always see a light reddening of the eyes, and many patients are coming with paper towels to scrub away the tears. Again, we had already a very interesting and very informative talk about the speech in PSP patients, and we have analyzed our PSP patients again against patients with Parkinson's disease, And what we hear, what we have seen is that the voice is low and the tone is very high in PSP patient, independent from age and from the gender. The speech is hypophonic and atactic and sometimes very spastic also. And the spasticity or the spastic voice depends on the problem with breathing. We have analyzed this again against Parkinson's disease patient. We have analyzed the mean ventilatory volume. The mean ventilatory volume is the volume of the lung which a person can breathe in and out in a certain time, let's say in 1 minute. And you can see patients with Parkinson's disease are almost lying above 60%. Normally you would have 100 to 120%. But interestingly, patients with PSP are almost all below the line of 60%. Some patients really report that they have breathing problems, but most of the patients do not realize this because they do not walk so much. There was only one patient which was above this line, and he has been a professional saxophone player, so that's the reason why it's better. Okay. Right, just very common is the applause sign. You know all of this? You know the applause sign, the patient. And very typical is this moving. Thank you. You can start. This is very typically the hand clasping. And also the writing of PSP patient is somewhat different extra steps are really dangerous. It's not only the posture loss, like behind one, but these extra steps, sometimes really cause falling. Thank you. Now let's have another look. No. Play it again. Yeah. Look at her arms. And she has a wide range of the steps, and now comes an extra step. Ups. This is typically for PSP. Doesn't happen in Parkinson's disease. Okay, great, thank you. Okay. The clinical examination includes the relatives. When you compare relatives of Parkinson's disease patients with the relatives of patients with PSP, the relatives are really close to the patient. They often talk much more than the patient, obviously. They are experts of the symptoms, really valuable, and we haven't ever seen any open conflict in the relatives of PSP patients as compared to Parkinson's. When a couple of Parkinson patients are coming to us, they get easily into a quarrel, even during the visit at our office. And in PSP patients, although the disease is much more progressive than Parkinson's disease, although the patient are much more disabled, we see that the relatives are much better together with the patient as compared to Parkinson's disease. Yes, thank you. This was just a short look.
Thank you very much, Dr. Lorenzl. You are available for a little discussion, I think.
Yes.
Quindi se c'è qualcuno che vuole chiedere qualche cosa, io avevo una puntualizzazione da fare. I appreciate very much your attention in the detection of the clinical and physical signs. Have you some suggestion about the instrumental analysis able to distinguish Parkinson's disease from PSP or not? Ho chiesto se ci sono delle strumentazioni tecnologiche che possono fare di quindi aiutare il clinico, perché io ho molto apprezzato l'esame obiettivo che ormai i medici non fanno più, per gli studenti se stanno in medicina chiedono subito la risonanza magnetica e si dimenticano di visitare il paziente, quindi sono molto lieto che abbia riportato questa attenzione sulla physical examination e quindi chiedevo se c'era proprio qualche strumento che poteva aiutare.
Yeah, the most easiest examination we are using is to measure the posture when the patient is standing on a platform, and we measure his postural ability. You can distinguish PSP patients from Parkinson's disease patient. And the second test we are using is walking on a certain floor where a computer is following the steps, and by analyzing the step length and the distance a person can walk, you can distinguish between PSP and Parkinson's disease. Unfortunately, I have not brought the slide, but when a PSP patient tries to stand still, like I do now, it cannot stand still. There is a certain up and down movement, what we can see. It's always a little bit going like that one. A Parkinson's disease patient is really standing like that one. The line is almost flat. And this is very significant, actually, a difference. We have now measured about 40 patients with Parkinson's and 30 with PSP, and it looks like you can use that one even in the early phase as a mechanical diagnosis. We know in the early phase that the MRI or even PET imaging is not sufficient to distinguish between Parkinson's and PSP or other neurodegenerative diseases.
So your recommendation is to pay very much attention to physical examination, because the first line to the early diagnosis of the
right, and easy electrophysiological tests, okay, like for the posture.
Okay. Ci sono sono altri prego.
I'd like to ask two things about the intellectual capacities of papers with PSP, and then about the awareness of the person with PSP. Since, for example, I don't know, sometimes if my father is completely aware of what is going through, or not. It's becoming difficult to have, a complete dialogue with him.
Yeah. I mentioned a little bit the different forms of PSPs. We know today that there are 7 subtypes of PSP. But in the classical PSP, the Richardson syndrome, you do not see a dementia at the very beginning of the disease. Obviously, these are old persons, and they become a dementia during the progression of the disease. But what we see very early on is called bradyphrenia. That means a slowing of the thinking. So if a person has enough time to complete the work or go into the discussion, he or she can do it quite well at the beginning of the disease. This will get worse during the course of the disease. However, we even have experience, at the very late phase of the disease, and we have seen that the capability to make decisions is very well preserved, but complex thinking stuff they cannot perform.
And about the awareness.
About the awareness.
Right. I think they are aware of a lot of things. And it's not surprising that it might change from day to day. It depends on the physical condition or sometimes really on the hydration or something like this. But we have observed that very frequent. To be honest, we made some neuropsychological tests on these patients. And what we have seen, we did the test on every day during 1 week. And the differences between the days have been so huge that on the one day we would call him as a demented patient, and on the other one we said, no, he can make decisions and whatever. But we do not know exactly why these are huge ranges in there. We have compared our dementia tests with a complete different group, with patients with brain tumors, and we have seen in these patients, that there is also a huge difference from day to day in these neuropsychological tests. So actually, it's really hard to get on the value of such tests when we have such huge differences from day to day.
Altre domande? Well, for me, you presented in the slide the mean time survival of these patients, and if I see well, it's very short, correlated with Parkinson's disease.
Yeah.
Have you some explication for this different survival rate?
Yeah, of course. The mean determination of the survival rate is the swallowing disability, PSP, which occurs much earlier in PSP than it does occur in Parkinson's disease. And we know the cause of death is most often pneumonia related to the swallowing disability.
Avete capito, no? Bene, se non ci sono altri interventi, thank you very much, Dr. Lorenzl. We appreciate very much your presentation.